Barry. I'm the Clinical Programs Manager at the Heart Foundation in New South Wales, and I will be emceeing this event. Thank you for joining us. I'd like to introduce Carolyn Ashley. Carolyn is an Associate Professor in the College of Nursing and Health Sciences at Flinders University. She's a Research Fellow with the Country Heart Attack Prevention Program of Research, and she's also the incoming President of ACRA. Caroline has expertise in registry and is the lead of the South Australian Cardiac Rehabilitation State Audit. So it's my great pleasure to welcome Caroline to her presentation.
Thanks, Kate. I'm just waiting. Oh, here we go. I'll just share my slides. So thank you very much for that kind introduction, Kate. I'm really honoured to be presenting, or sort of kicking off, I guess, the launch of the National ACRA Heart Foundation Quality Indicators for Cardiac Rehabilitation. This has been the culmination of probably 2.5 years' work. But before I start, I just want to mention some housekeeping things. Can we request all participants to keep themselves on mute until the Q&A session? Please use the chat function to post your questions. And just to let everyone know that the event will be recorded and it'll be posted on the ACRA and the Heart Foundation websites. So just to start, I want to acknowledge the people that have been, or the groups that have been involved in this. We started off, it was the think tank, which I guess discussed the whole idea of developing quality indicators in 2018, was at a meeting that was held in Adelaide and hosted by Health Translation South Australia. Health Translation South Australia are an advanced health research and translation centre, of which there are a number across Australia, and they hosted the meeting. We had the Heart Foundation have been involved in from the outset, as has ACRA. And I also want to acknowledge the NHMRC Clinical Research Excellence for Cardiovascular Outcomes group that ran a grant scheme in which we were successful recipients of the targeted grants funding mechanism, which has basically supported the work of this group for the past 2.5 years. So it's really been a great collaboration. I'd also like to acknowledge that the traditional custodians of the land upon which I am meeting today is that of the Kaurna people, and I'd like to pay my respects to their elders, past, present and emerging. So what was the problem? What did we recognise was the reason for why we all had to get together and talk about the future of cardiac rehab? We know that guidelines recommend referral to cardiac rehab, and we know that there's a really strong body of evidence to support that. But referral rates remain between 30 and 45%. Attendance and completion remain around 20 to 60% across Australia. Contemporary Australian data are lacking, and the reason why data is important is in health services, we need to be able to measure what we're doing in our practice to identify the gaps. And we already know that cardiac rehab services vary widely across Australia in their content, structure and delivery. Just as an example of cardiac rehab program variability, Abel et al. In 2016 looked at exercise cardiac rehab and identified that only 62% performed a post-assessment of exercise capacity. They also showed variability in the sessions per program. They range between 3 and 42, so quite a difference. Jackson et al. Did another survey in 2018 and showed that program length varied between 1 and 30 sessions, and the essential components that were delivered in a cardiac rehab program varied from between 68 and 97%. So improving quality is quite important for cardiac rehab programs if they're going to be effective for patient outcomes and their experience. So the benefit of measuring, service quality means that we can have data from multiple health services to support benchmarking, monitoring service effectiveness, and identifying areas for improvement. So what did we do? In December 2018, we convened the National Think Tank, which I've mentioned before, hosted in Adelaide. The purpose was to share activities on measuring cardiac rehab services. We had an idea that it would be important to develop a set of national quality indicators, but we wanted to get consensus for this. We had representation from consumers, clinical personnel, research, data, health and policy experts. And the key output for the day was to establish a cardiac rehab task force to progress the decisions that we made. That's a little snapshot of our think tank. So who were the participants? I mentioned that they were we had a wide variety of stakeholders. Wendy Keach and myself represented Health Translation SA. We had a number of people from the Heart Foundation and from ACRA. We had 2 consumers from Health Consumers Alliance, which is the group of health consumers body that is in South Australia. We had representation from Queensland Health, Flinders University, the University of Sydney and the University of Melbourne and the University of WA. We also had representative from the Cardiac Society of Australia and New Zealand. We had representation from Northern Territory, from the Healthy Living program, and also from the country SA Health Integrated Cardiovascular Clinical Network in South Australia. So I mentioned before that the purpose of the think tank was to sort of do a scoping exercise to see where we were at. And we wanted to recognise that there was already some cardiac rehab measurement activities existing across Australia. In South Australia, we already had a central web-based database with uniform standardised data entry used by metropolitan and country clinicians as part of routine practice. In Queensland, we had the Queensland Cardiac Outcomes Registry, which had recently at that time added a cardiac rehab module for measurement of cardiac rehab practice. New South Wales had just developed quality indicators in a data dictionary and were piloting, data collection across 41 sites. And Victoria had done some previous work in the area of cardiac rehab databases and testing methods for data collection. Task force members, over the time, we've had, as I said before, the co-chairing role was between ACRA and Heart Foundation. So it was a truly collaborative partnership. Between 2018 and 2020, Rachel Foreman from the Heart Foundation and Robin Gallagher as president of ACRA led us. And between 2020 and 2021, Kate Ferry from the National Heart Foundation and Kim Gray as president of ACRA led us. The members, myself, Emma Thomas, who worked for the Heart Foundation and then transitioned to University of Queensland, Rob Zekin, who's part of New South Wales ACRA and is a clinician with New South Wales Health, Samara Phillips from the Queensland Cardiovascular Outcomes Registry, Tom Briffer from Curtin Uni, Julie Redfern from the University of Sydney, Steve Woodruff from Queensland Health, and Alex Clark, previously from the Heart Foundation. And I want to take a minute to say thank you to all of these contributors to the past 2.5 years of work to develop the cardiac rehab quality indicators. So how did we develop them? So we started off with the think tank. I've talked about that. And then we formed the National Task Force, and in the task force we discussed priority areas for quality improvement. We reviewed the evidence on variability of care, which can drive quality improvement. We consulted with experts on areas that can be developed into measurable indicators. And from that, we developed a set of 11 quality indicators, and they were preliminary quality indicators. Then we conducted an email consultation and request process, and we asked clinicians, and these were through ACRA members, to rank the 11 preliminary quality indicators in terms of their priority and significance. We also did an email consultation and request for ranking and utility of the preliminary indicators with the multidisciplinary cardiac rehab opinion leaders. So we did consult widely, I believe, on the development of this project. We then went through a process of refinement of the indicators for consistency, and we developed what we're calling a data dictionary. And Robin is going to explain a little bit more about that feature a little bit later in a practical way. We conducted a workshop-based consultation process once again with cardiac rehab providers at one of the ACRA national conferences. I think that was in 2019. And once we developed our set of 10 quality indicators, we published them in a publication and talked about the whole concept of field testing, which Robin once again is going to talk about. We've also just finished a review by the Australian Institute for Health and Welfare Metadata online registry. They're a group of experts who are a repository, I guess, for data dictionaries and data elements for different databases across Australia. And they have reviewed our variables to align them with national data standards. So we feel that we've been through quite a rigorous process for the development and review of these quality indicators, and that they are now ready to be used by you as cardiac rehab clinicians. This was just an example of the way we collated the feedback from the stakeholders. I mentioned we had ACRA members and other opinion leaders who gave us ranking suggestions on different quality indicators, and that process resulted in the final 10 quality indicators, which you will see today. So just in closing, I want to just make a point that I think the lesson that I've learned from this process over the past 2.5 years is the benefits of collaborations to discuss, communicate, and gain support in progressing in important initiatives. And I think that we can call this quite a success story. So now I'd like to hand over to Robin.
Thanks very much, Carolyn. We might just take a moment to excuse us while we share our screen. And excuse me, I just get it full. Okay, so thanks very much to everybody. I presume you can now see my main screen. So I'm going to talk a little bit about the practicalities of how you could use this, the indicators and the data set and the data entry and collection tool that we're providing to everybody. And I will show you that live in a screen share later on. So what you can see here in front of you are the complete 10 indicators. And I'm going to concentrate on smoking as an example today, just to help us work through how the dictionary and indicators can be used. So for assessment of smoking, the indicator is patients who commence cardiac rehab are assessed for smoking use.
Excuse me, Robin, sorry to interrupt, but I think you need to put your screen on slideshow, and we can't see your quality indicators at the moment.
Excuse me. Excuse me, is that working, please, Carolyn? Okay, thumbs up, thank you. Please, yeah, forgive that little slight. Now, so what I'm going to be talking about now is the quality indicators, and I'm going to use smoking as an example. So the indicator is actually a performance indicator, whether a process is done, but built into it is a potential outcome assessment as well. And I'll go through how that can be. So in this assessment of smoking, patients who commence rehab are assessed for smoking use at initial and reassessment and offered smoking cessation counselling or referring to counselling if they are a current or recent smoker. So you can see within one indicator, there are a few things built. And certainly that's why we need this data dictionary. And this is the most current data dictionary, and so much work has gone into it, as Carolyn has outlined. In the data dictionary is important information. The first of those are the data elements, the data, the numbers you need to collect. The second of those are when you collect the type of information and when you collect it. And in section B is the detail of the indicator, the codes that are put in, and an explanation for why this indicator is a justifiable measurement of performance. So when we look at the data elements in section A, what you can see is the number, the type of variable that is put in. So for instance, for smoking, it would be smoking status, smoking referral at the initial assessment and at the reassessment. When you then look further into the data dictionary, you can see that the codes that we're recommending. So for instance, was the cardiac rehab patient smoking status assessed? Yes is 0, no is 1, and 99 is unknown. So you might wonder, why are we providing the specific numbers that should be used? The reason for that is standardizing is vital. We need to, at some point, share our data, and people who look at our data other than ourselves must be able to understand it. So for instance, we have coded a daily smoker as 1 and a weekly smoker as 2. And while those numbers don't give us specific analog information, it's a code. But all across Australia, we can now share that information. So then when we look at part B in the data dictionary, you can see that it expands much more. So you can see the codes. Once you've got the codes, how you can actually calculate a rate. Because we're always interested in the rate of smoking rather than the numbers of smoking, because it is always relative to the number of people who are using your service. And if you look down the bottom, you'll be able to see the rationale, the reason why this indicator is being collected and how it connects up with the ACRA core components that guide cardiac rehab nationally. We also have a data collection sheet. It's basically an Excel spreadsheet, but it has some formulas embedded. You can see here on the right-hand side how smoking is scored and how you can use it, so that down the bottom you can get a total count immediately. So now I'm going to attempt to do a screen share. So I'm going to go to a new share, and hopefully it comes up. I'm going to ask Carolyn to give me a thumbs up if all is well. Carolyn, can you see my share screen?
I can see.
That's exactly what I've done. I'm going to download.
Yep. Download, yep.
Yeah, so on the Heart Foundation, this is live. You can download the data dictionary from there. And there's your data dictionary, available immediately for your use. Importantly, you can download the data collection spreadsheet. And we're going to have a little look at that. Okay, Leon, can you see the spreadsheet? Okay, so what we have here is there is some identifying information peculiar to your service. You can't see it. Okay, so you can now see live the data collection and storage sheet. On the left-hand side, there's identifiable information. So for individual health sites, you can put identifying information there. But should you wish to share it across services, or across districts, or even within the state, you can remove that information so it's no longer identifiable. There are drop-down screens. So for instance, if I wanted to put a new patient in, I can put their first diagnosis, the primary reason they're admitted. I can put an additional diagnosis, primary PCI. I can add further diagnoses to this. And what will happen is the total counts will increase. So I'm interested in smoking. So I scroll over to smoking. And here I can update information and just say yes. I've got to enable editing, pardon me. Doing things live can always be a bit checkered experience. So for smoking, you can have referral information. You can put in the actual wait days. You can change the eligible patient indicator. You can put in referral diagnoses, and you can alter this sheet in any way that suits you. But we recommend you keep the original sheet because it enables us to standardize and share these things. I'm now going to go back to the slides. Thank you for your patience. Okay, so that's how you can use the dictionary and the data collection tool. It's so simple. And many people have been using this already for their service. So talking about field testing processes now, there's basically 4 steps. And the first step is the one that's surprising to you. You have to understand what's happening with your data right now. How is your service patient data collected and stored? Are you using pencil and paper? Are you putting it in a filing cabinet? Is it an access database that you can't use? Who does this data collection and storage? How much time does it take? Can you easily create reports? Can you measure the effectiveness of your service? And importantly, are you collecting the data you actually need? Step 2, you need to decide what your service needs to build on the efforts you're already making. Pick the indicators that are relevant to your service needs right now. Again, we recommend the whole set of indicators can be used, but you, of course, can reduce those as needed. Staff training and support is needed, and we recommend you connect with your local quality team and managers so that you can use their resources as well. But of course, all of this takes commitment. Quality improvement requires repeat data collection, not a one-off. So you are committing to perhaps annual data collection, perhaps a snapshot or continuous. One important thing that is often not considered is to record the associated workload. How long is it taking you to do this? Step 3, you should decide how your service can benefit best from these quality indicators. So you might decide to start small, to understand and improve your own service. Many people are collaborating within the district, however, and people understand their service versus others, share the workload, include a researcher, a manager, and develop improvement processes together. And other people are collaborating across districts. And in that situation, oftentimes including a researcher or someone who knows about policy, maybe the ACRA Association, get a bit of money and have a high-level process. And this will ensure that changes made will be sustained and not abandoned after the first effort. Step 4 is what we're asking from you. Please provide some feedback to our task force. Tell us which measures were useful to your service. Tell us where the indicators or dictionary were incomplete, annoying, or unrealistic. Tell us about the workload and resource issues you faced. And I really encourage you to share your results at the ACRA seminars and conferences. Thanks very much. So I'm handing over now, I believe, to Tess.
Hi, it's Again, thank you very much, Robin. Just while Tess slides, this is an accredited exercise physiologist working in cardiac rehab in Sutherland, South Wales. Tess uses the knowledge gained from her research degree, clinical work and teaching to provide the best quality care for patients. Could I just reiterate that if anyone apart from Tess, could you mute yourself, please, because there is a little bit of background noise. So thank you very much, and Tess, over to you.
Thanks, Kate. Good afternoon. As I said, I'm the exercise physiologist in the cardiac rehab team here at Sutherland Hospital, and I've been using these quality indicators. So as we know, COVID pandemic forced a lot of changes within the way we practice and the way we deliver cardiac rehab. Like many services, we introduced a telehealth program as a solution for patients to continue to access cardiac rehab. In developing the telehealth program, we took time to reflect on our service as a whole. I was fortunate to be part of the ACRO mentoring program. And at this time, Carolyn and Bridget linked me in with the quality indicators, or a draft version of the quality indicators, the associated database and the data dictionary. I've then used these to not only review our service, but to hopefully add value to our service as well. So we reviewed our current practice in relation to the 10 quality indicators. You can see there that we felt that 5 of the quality indicators we could do in a better way than what we were. That being quality indicator number 1, percentage of patients referred to cardiac rehab, not necessarily the percentages itself, but actually getting that statistic. Number 6, which was medication adherence. That was something that we were asking, but we weren't asking in a formalized way. Number 8, health-related quality of life. We weren't using a health-related quality of life tool. Number 9 and number 10, we felt we were partially doing. So risk factor reassessment was something that we were doing at mid-program review, but not necessarily at the exit assessment time point. And care transition reporting. So we were providing a plan and report to the care team, but weren't providing that plan to the patient. So we felt we could do that. The other 5, we felt we were doing well. Our time to enrollment was less than 28 days. We were doing a structured risk factor assessment at an initial time point. We were screening for depression using the PHQ-2, PHQ-9 when necessary, and the depression element of the PROMIS 29, and assessing smoking at initial and post, and referring when necessary. We're using the 6-minute walk test for our exercise capacity pre and post, and treadmill or bike tests as needed. So for the purposes of today, I'll focus on the 5 that we felt we could do better on and share what we've done. So the first one there, percentage of patients referred based on eligible patients. We found this difficult to accurately evaluate. Where I work here, we have multiple referral sites, somewhere between 6 and 10 usual sites, and we're unable to obtain that information from these offsite eligibility lists. And all cardiac surgeries performed offsite. So we felt that we would plan to evaluate specific sites that we did have access to that information, and we're currently undergoing that at this time. For the medication adherence within the quality indicator document, ACRO recommended questions, specific questions, as you can see that I've listed there. And we've added that into our initial and exit assessment battery, and are asking those for every client that comes through. For health-related quality of life, ACRO recommended within the document 3 different quality of life tools, one being the Euroqual 5DL. We used that initially. It was a free tool. It had 5 questions and was quite helpful to use during telehealth because it wasn't that demanding on time to be asked in this format. However, we did get a bit of feedback that the patients didn't like the questions themselves. And since then, we've now trialed and are using the PROMIS 29 version 2.1, which we're using in person. And it then cross-checks anxiety and depression as well as it is another screening tool. For number 9, risk factor reassessment. So what we've done is we've formalised our exit assessment process. We've rewritten and reconfigured our data collection sheets that we use here with each patient to include structured prompts in that exit assessment, which you can see there on the right-hand side. So we again ask that medication adherence question along with other aspects as well, and have a section where we can write a plan or which then links into quality indicator 10. So we improved the detail that we had in our plan and report to the care team based on having a more structured exit assessment. And we're also providing that entire sheet, as you can see on the right, to the patient, which includes their specific information of initial data and exit information with the plan included as well. So by using and assessing our service in relation to the quality indicators, we've updated forms, we've updated our database, and that was a database based on the one that Robin just shared. We've added a little bit to that database just because we generate our reports using a mail merge format from that Excel spreadsheet. So we've got a few extra columns in there that we use as well. And we've formalized new processes to make sure that we're doing this in a uniform way. As a result, we feel that the patients have valued this change or value what we're doing now. However, nothing goes without challenge. Initially, we rolled this out when we were only doing telehealth within the middle of last year. We had a telehealth program and telehealth education as well. Now we're running 3 exercise-based programs and 2 different education programs. So we are still doing telehealth, but we've got gym programs and also a hybrid combination of the 2 as well. So we're currently having to integrate these quality indicators into these new programs as we change. So what we've learned through this process, the inclusion of telehealth prompted service-wide reflection, which I'm sure it did for a lot of people. The perceptions of the care were different. So we felt that we were assessing medications really well, however, weren't specifically asking these questions in relation to adherence. So that's helped us be more uniform from that front. We've updated forms, which we were going to do anyway, but have now done maybe in a more complete way, which has helped then deliver our care consistently. We're reevaluating or evaluating what we're doing consistently. We're seeking to have value-added changes, not just change for the sake of change. And we're being flexible in the way that we're doing this because us, like everyone, like the world, are in a current adjustment period to what is going on. And we anticipate that to continue to happen for some time now. And as we all know, data entry takes time. We've got more than 130 people in our database between January and May this year. So it takes time and just making the time for that as well within our normal practice. So the path forward, so moving forward, what we're doing, as I said, we're going to continue to evaluate what we're doing to meet these quality indicators and review, particularly for us, that first quality indicator and see what we can do from different sites. With the forms, we're trying to increase our usability of what we do here, just to increase efficiency. With the database, we're just reviewing our use and the time taken to use that, and looking for any trends or gaps that it might show, and continue to have efficient processes just so that we can have more patient time or better use of time. You can see there on the right hand side, so just based on the database, I've just written a couple formulas to help show some graphs of what we're doing and who we're seeing. So we're going to do a mid-year review of the data that we have in the database at the end of the month. But what you can see there now is the type of patients we're seeing or who's coming in, the diagnosis, and then the diagnosis divided by age, with each color being a different age. So we can know who we're seeing. And then below that, the age range of the people enrolled in the program divided by sex, so blue being male and orange being female. So having this information has been really helpful to know who we're seeing. And hopefully we'll find out more information as well. We'll continue to seek consumer feedback. It's important in the way that we have value in what we do, and continue to be open and transparent with patient data to patients to increase their knowledge of their health. So that's what we've learned so far through integrating the quality indicators. Thank you.
Tess, that was a very, very informative presentation of great work that you've been doing. We have allocated 5 minutes for specific questions to Tess, and we already have one from Carolyn asking, do all the team enter the data for each patient, or is it one person who is actually responsible? Yeah,
it's a good question. Previously that I've been that person who's entered most of that data, and one other nurse. So we try and make the same people, or keep the same people doing it. We've recently got an administrative person for 8 hours a week, who has then had has taken on that task. So at the moment it's one person, but that might change over time.
Great, thank you. Anyone else like to? We've got one other question. Tess, have you discussed or shared your data and processes with senior people within your department or your local health district?
Well, within our department, within cardiac rehab and cardiology, they know how we're operating and what we're doing. And that's something we've just recently this week got a notice board within the CCU of the hospital, where we're going to put like those graphs that you saw monthly in there, so that we can share with the staff and patients who we're seeing. So that's the extent of that so far, but not necessarily at an LHD level.
Okay. Anyone else like to take themselves off mute and directly ask Tess a question?
Okay. There's a question there, Kate.
Yeah, we have one question there.
Yeah.
Kate, we provide cardiac rehab remotely. Are there any suggestions for assessing exercise capacity or 6-minute walk test remotely?
I can try and answer that, but I'm sure there's better people to answer that question. There's a questionnaire that you can use that helps measure exercise capacity in METs. So that's a questionnaire that you can use without doing a physical assessment. You can use a 6-minute walk test, I guess, is the distance walked within 6 minutes. So they could set up their own course, but it just would have to only be repeated within that same environment, rather than maybe being compared to other standardized measures.
Okay, that's great. Thank you. Okay, in the essence of time, we do have a 10-minute section at the end we've allocated for question and answers. So please keep typing in to the chat function, and we'll endeavour to answer those at the end. So I'm just going to quickly, I'm not going to share slides. I'll do this quite quickly. But my section that I am just going to briefly talk about is relevant national and state government stakeholders to inform and influence a pathway to the implementation of the quality indicators. And just to share some examples with you, in New South Wales, we have the New South Wales Agency for Clinical Innovation, of which the Cardiac Network is one of the networks. So it's already been alluded to. We have actually worked very closely with the Cardiac Network over many years in regards to the development of the indicators, and also they're very aware that we're actually hoping to get them built into the electronic medical record so that it is actually prospective data collection in a seamless way when care is actually being delivered, so it will be business as usual. A like organisation in Victoria is Safer Care Victoria. And where you, in states or territories where you have clinical networks, I'd encourage you, if you haven't already had the conversation, to start the conversation now where you have the indicators and the data dictionary, and see what you might be able to do in regards to promoting them. And obviously our plan is to have them built in where we can into the electronic medical record. The Heart Foundation over the years has done a lot of advocacy in regards to data collection and the importance of the value of data. And one success story that we have is the Queensland Cardiac Outcomes Registry. The Heart Foundation in Queensland worked very closely, and as a result of that, that registry is actually now set up. And Samara Phillips, who we've already identified, is a member of the task force. So her position now is a permanent part-time position as a result of some of the advocacy that the Heart Foundation has actually successfully done. We also at a state and territory level, and also at a national level, where possible, to in pre-budget submissions and election submissions, to highlight the value of data collection to drive quality improvement in secondary prevention and cardiac rehab. So we'll continue to do that. So they're just sort of some of the examples at a state and also at a national level that will help with influencing the implementation of the indicators, so that it will actually be data collection and it will be business as usual. This probably leads very well into my introduction to Julie Redfern, who is a Professor of Public Health, a practicing physiotherapist, a research academic director at the School of Health Sciences, the University of Sydney. Julie is the Chief Investigator on an NHMRC Synergy grant, which we all know now as Solve CHD. She is the co-chair of the Clinical and Preventive Cardiology Council of Cardiac Society, and she's also the co-chair of the National Secondary Prevention Alliance. Julie is going to talk to us about Solve CHD, which is another fantastic example at a national level on how we'll be able to work and collaborate together to influence the implementation of the indicators. So over to you, Julie. Thank you.
Thanks, Kate. Hi, everyone. So I'm doing my slides, right? Okay. Let me do that. So thanks, Kate. Thanks, everyone. Before I start, for those of you that don't know me, I should say that I am a physio. I started on this journey when I worked as the head cardiology physio in cardiac rehab at Concord Hospital in Sydney back in 1999, and have since done my PhD and have been working with Professor Tom Briffa, who's on the line, and Robin Gallagher, as many others of you on the call, trying to close these evidence practice gaps for people after they leave hospital with cardiovascular disease. So I've been asked to talk to you a bit about Solve CHD, so I'm going to give you a bit of an overview of what that is and why it's relevant. So a few of us on the call, particularly Tom, Robin Gallagher, Carolyn Asterley and others, and myself, applied for an NHMRC Synergy grant a little while ago. And I think it's really important to just say what the Synergy grant scheme is about for those of you that aren't familiar. So the NHMRC Synergy grants are about supporting outstanding multidisciplinary teams of investigators working together to answer major questions that can't be answered by a single investigator or a single project. And having worked in this space for a long time, having been involved in these indicators and various other things, I could see the alignment here, that this was a major issue. It required a multidisciplinary effort, and it couldn't be answered by all these different projects, and it needed this kind of overarching support and funding that wasn't you know, from a whole group of randomized controlled trials. So hence, I could see the alignment and applied for the Synergy grant. The good news is, as many of you probably know, we were successful in getting that grant, and we were awarded $5 million to tackle this problem over the next 5 years. So these are the chief investigators, some of whom you know, who I've already mentioned. And these are the associate investigators. Again, many of the people involved on the call in different ways. So what is Solve CHD? Let me just try to. Okay, so what is Solve CHD? Our vision, as I said, really is to bring all of that work over the last 15 or 20 years together to modernise the after hospital care and reduce the burden of heart disease by integrating data, technology, partnerships, and also supporting capacity building. We're in an enviable and very lucky position. I'm absolutely ecstatic to say that myself, Tom, and Robin, who are the top 3 people named on the grant, are not cardiologists. Sorry to all the cardiologists on the call, but we have myself, a physio, Robin, a nurse, and of course, Tom, an exercise physiologist / epidemiologist. So I'm really proud of that, and I make sure I point it out to the cardiologists quite frequently. So we kind of have 4 main goals. And one is to facilitate a national system led by the jurisdictions to collect cardiac rehabilitation data and to develop a national reporting platform to enable data-driven quality improvement. So what is that all about? That's about this conversation, and this work is a very first step in this process. So the next is to support all of you to try to collect some of this data, and then to invest in some systems sort of at your state and jurisdictional levels to help automate and change the way we collect data a little bit, and then to have a place where it all goes nationally so that we can summarize data for all of you at your service level, or you can do it yourself, as Tess has already demonstrated very effectively, or it might be states can use that data to show what's happening in their state, or we can show what's happening across the country. It's been really interesting for me. I've run a large project in primary care where we see what the GPs can do. And GPs, if you don't know, it's another whole talk that I could give if anyone wanted to hear it. But there is a practice payment called a QIPIP, so a Quality Improvement Practice Incentive Payment. And GPs or GP practices get paid money from the government in order to collect data and to feed it back into these platforms. So that is not going to happen in what I can understand in rehab, but just to show you these types of arrangements and these types of moving in this direction is really the way forward in terms of going ahead. For me, the simple way, you know, the piece that I want to support in this project as well is about, I've said it many times, so those of you that have heard me speak have heard me say this. When I was a child and I went to the GP, I would sit in the waiting room, my name would be called, I would go in, the receptionist would put a folder with my information on pieces of paper in front of the GP would measure things, do things, write things down, back in the folder, into a filing cabinet. And that's how things used to be done. But now everything is done straight into a computer. All of our referrals, all of our scripts, all of our blood pressures in drop-down boxes and whatnot. So my real vision is to try and use this money to not only support cardiac rehabilitation services to collect data, but to have the systems created that you can move to an EMR system across the country. So that's our big vision. And that's what we want to support you all in trying to move towards, so that we can catch up with some of the other hospital and primary care services. But just going on to a couple of other things, we also want to create a multidisciplinary sort of research capacity, community and engagement in this space. And we have a bunch of activities to support that and develop some future health services research leaders, and also have a network, which I'll just talk to you briefly about in one. So as I already said, we want to have this transformative data that can be used at the service or at the program level, the LHD, for example, the state, and then nationally. And then once you get data like this, we can try and leverage it with the government or policymakers to try and get better investment in this space and try and close that gap with how many people we get access to through cardiac rehabilitation services. So we want to do this by allowing states, so states and territories, i.e. jurisdictions in this language, to drive their own way of doing this as best suits their own states and territories, to get local government and stakeholder support. So you'll probably hear from people soon around who are leading things in your area. There will be ownership of the data by jurisdictions or states and services, and then feeding in of the identified data with the common indicator set, which is why the indicators become really important. So we can all be collecting the same thing. Of course, you can collect more things, but we want to collect a core set of the same things. So then, as I said, we can use that for benchmarking, reporting, quality improvement, talking to government, and many, many, many other things. So the other thing, just to let you know here today, for those of you that have heard of it, the National Cardiac Registry is coming, and it's being supported by the federal government. And Solve CHD is going to be an affiliate of that National Cardiac Registry. And we'll be collaborating and partnering to facilitate the governance of sustainability through that approach. And I think that's really important because it's funded by the federal government. Tom Briffer and David Brieger are involved in the steering committee and will be being our advocates there. But I think it shows that alignment, that interest, and I'm really proud that we, as in secondary prevention cardiac rehabilitation, will be the first affiliate group to be able to and invited to be associated with the National Cardiac Registry beyond sort of PCI and the more immediate things going into that registry. So I think we're in a very unique situation where we have the funds to get on board with a big program like this funded by the government. So I really hope together we can really try to make this change that we haven't been able to make and get the investment in this space. But just before I finish, a couple of things to highlight. There's many things I could tell you about. Some of you have heard me talk before. We are have open or closed it now, but we've got a number of projects that we'll be supporting for both EMCRs and broader groups in the space. We also have PhD scholarships, which are actually open definitely at the University of Sydney, but they're coming at UWA and Deakin University as well to do a PhD scholarship on this work. And we also have a whole group of fellowships, and we're currently recruiting some postdoctoral fellows to do some of this work as well. But we will also be investing in the jurisdictions of the states and territories. So it is my vision to use this money to give out, as it were, to try and really transform this space. So I hope you can come on board, and happy for anyone to speak to me about that or how and if you might want to be involved. So in terms of the national network, we've launched that network. We've got a website. That's the website there if you want to go and have a look at a few things and preliminary things to get us started. We're only just really sort of kicking off. And some areas are still under construction, but please also follow us on Twitter or LinkedIn where we're posting anything that as coming up. But you can also message Julia Ning, who's coordinating all of this work, and that's her email there. But we'd love to hear from you. We'd love to work from you. We will be doing some work to unpack exactly what EMRs are used in your hospitals, how we can sort of help. And as I said, there will be leaders potentially within your states and territories. So I think that's all from me, and I'll stop sharing. And yeah, so a bit of a different tack, but I guess that gives you where we can go and that we have some resources to really drive this. So that's all from me. Thank you, Kate.
Great, thanks very much, Julie. A very, very exciting project. Before I hand back over to Robin Gallagher, I'd just like to do an introduction, which I didn't get to do before she started last time. So Robin is a professor of nursing at the University of Sydney, where she leads a team researching secondary prevention of cardiovascular disease. Her focus includes contemporary health technology, cardiac rehab, health literacy, and cognitive impairment. Robin was absolutely a co-driver of the development, the piloting of the cardiac rehab quality indicators in New South Wales, and very much a facilitator to have them adopted at a national level as well. So it's back to Robin now, and Robin is going to facilitate the QA session. If anyone has specific questions where they'd like to take themselves off mute and ask Robin. A number of questions have been posted in chat, and thank you to the people who have been responding to the various questions. So yes, anyone who would like to ask a question, please feel free to take yourself off mute, and either Robin or Julie or Caroline or myself will answer. So thank you, Robin.
So what you need to do preferably is raise your hand using the Zoom function, or you can, if you're on video, you could raise your hand visually so I can spot you. But I'm going to start off by noting a question was, what would your advice to others be about starting data collection? I don't know if Tess is still on board, but she might be able to answer for us.
Yeah, sure, I'm here.
Yes.
From a data collection standpoint, we already were using an online database. We then adopted the new one that you showed. And so then our process didn't change too much around adding data to it, because that was something that we were already doing. If you're not using a database, just allocate maybe a little bit of time to using it, but it's very user friendly. There's drop down menus for almost everything, and it becomes a quick process when you're used to using it, and it can help know what information to collect, because it prompts for that as well. So I'm not sure how helpful that was, but using it is the best way of getting better at using it.
That's absolutely helpful, Tess. Another question we have is for people who are already using QCOR, the Queensland Cardiac Outcomes Register, what should they do? And I guess Carolyn and I could answer that in part by saying we've collaborated with QCOR so that we know several of our indicators are in fact on QCOR. It would be best to keep working with QCOR, but of course you could add your own data collection using our current Excel spreadsheet if there were areas that you were really wanting to investigate.
Excuse me, Robin, can I interrupt there? It's Samara Phillips, who is the statewide cardiac rehab program manager for Queensland. So if I have got Queenslanders online, as Robin has said, I have been heavily involved with the data dictionary and the QIs, and currently none of the QIs are in addition to what we already collate on QCorp. So I wouldn't advise doing another data registry. I would just continue doing QCorp as you are, because we can extract all that information from our online system, which actually is a point of care tool. So it actually replicates your workflow currently, so you don't actually have to do additional data entry. So just continue as you are if you are a Queenslander.
What a fantastic opportunity, Samara, to be using an existing instrument where you don't have to do duplicate entry, right? So for every Queenslander on board here, I would be totally recommending this system, and to get on board and be able to share your data across the state and look at your performance. And I'm sure Samara would be keen to be contacted by anybody on this particular call. We've had a bit of conversation on the chat function, which is about 6-minute walk test exercise capacity. So I'm going to leave that to the chat function and focus instead a little bit. People have started talking about what instrument for health-related quality of life. And some people are recommending the Promise 29. Just to remind you, the Promise 29 is in fact free. You can easily get it off the web, and Tess has provided that. Some people ask questions about how to understand the Promise 29. The Promise 29 doesn't have clinical cutoffs like some other instruments, but one of the most important things is to actually look at the raw scoring yourself as a starting point. But there are in fact scoring criteria there. I'm just checking if anyone wanted to unmute and ask a specific question. So I'm conscious that it's 2 p.m. So in the interest of time, I'll stop here. But I'm handing over to Carolyn, who has a very important duty today.
Thanks, Robin. Just in closing, just a few words that I want to say. So firstly, just about the presentations today, I've found it fascinating to think that our work that started on really right at the grassroots, which was developing the quality indicators 2.5 years ago, has then grown to something that Tess has shown us how to implement into practice. And Julie has shown us how this can work nationally. And we mustn't lose sight, of course, the reason why we're doing this is to measure our practice to improve the experience of cardiac rehab for patients and their outcomes. So you can see the whole trajectory of where this journey is going. And I think that that's been a real message, a take-home message from today. But in closing, I really want to say some special words about a member of our team. That's Kate Ferry, who has been working for the Heart Foundation now for over 12 years, maybe 13 years, Kate, I'm thinking in my head. And she has been passionate about the cardiac rehab cause and promoting cardiovascular secondary prevention around Australia. She received the Alan Goebel Distinguished Service Award in 2019, and her role with the Heart Foundation towards promoting cardiac rehab has been one of endurance and passion, even in a time a while back when cardiac rehab wasn't prominent in the advocacy conversation. So we thank you for continuing to raise cardiac rehab in people's minds. And she has been absolutely integral in developing the indicators and part of the task force and chairing us and leading us for the past year. And I just want to close today and give Kate a very special thank you. And we really appreciate your time with us and wish you all the best with your future endeavours. Thank you, Kate.
Thank you very much, Caroline, and thank you, everyone. It has been an absolute pleasure. Been a great journey, and I believe that everyone is well and truly on the pathway to greater things. So keep up the great work. There's a lot of leverage points now that there wasn't started, and I think that the collaboration is really strong, and I'm sure that everyone will be able to achieve great things. So thanks, everyone, and I'd just like to pay a special thanks to Julie and Ning, who helped very much in coordinating and organising the registrations for this today. We had over 220 people register, and we've had, I think at the height today, 120 people actually online. So I think it's a testament to the interest and the enthusiasm of people to be able to continue this. I wish you very well. And I'd also like to special thank you to Julianne Mitchell, who's online, because Julianne was my partner in crime at the Heart Foundation when we started this work back in 2014, and we've been able to gather some great people along the way to get us where we've got to today. So thank you, and thank you to my Heart Foundation colleagues who have really also helped greatly with this piece of work. Thanks, everyone. Have a great afternoon. Bye for now. My notes.